Rosso?
Yes.
Yeah. May I come in?
Come in.
Hi. I'm Donna. I'm going to be your nurse today.
Hi, Donna.
How'd your night go?
Wonderful.
Yeah.
Had a good night.
Hip is feeling good?
Yeah, I woke me up every 2 hours.
It woke you up, or did we wake you up?
No, you did. To move me.
To move you. Okay, and how were you with pain when we moved you? Did you need any medication before we did that?
No. Well, one time I did.
Okay. And have you been up and walking yet?
Yes.
Okay, good. All right. Any family coming today to visit you?
Yes, my husband will be here.
Okay, what we're going to do now, if it's okay with you, is I've got some students that are going to be coming in. I'm trying to teach them how to do skin assessments, make sure you're not at risk for any wounds.
Okay.
Is that okay with you?
That's great.
Okay. I'm Patty. This is
Hi,
Mrs.
Patty.
Rosso, and this is Andrea.
Hi, Mrs. Rosso.
All
You
right.
guys want to write your name up there so she can remember who you are. And how would you like us to refer to you? Mrs. Rosso, Ruth?
Ruth. is
Okay,
fine.
all right. Then we will do that. What I'm going to hand out to students is a little thing that we use. This is the little chart we use, what we call the Braden scale, a risk assessment to make sure we're taking care of everything a patient needs while she's here, before they go home, when they're home, to keep the skin intact, especially after surgeries, and if she's going to be coming back for more.
In order to accurately interpret and score the categories listed on the Braden scale, the interpretive language contained in each subscale of the 6 contributing factors must be available for review. In this case, the staff nurse and students are using a pocket card that outlines those details and allows for precise scoring. Facilities using online charting may include this information within the charting system database.
When you do get home, will you be preparing your meals for yourself?
Not at first,
Okay.
but we have a lot of things in the freezer that are, ready to.
So you plan on eating well?
Oh, yes.
Okay. And you're going to keep yourself hydrated?
Yes.
Okay.
Feels good to drink lots of water.
Okay, that's really good. Now, do you guys remember the importance of nutrition for when you're doing skin assessment or anything for patients' health?
Yes.
Correct.
Okay, because why?
High protein to build tissue.
Okay, all right.
Protein builds and repairs body tissues.
And how about adequate hydration?
Yes, definitely.
Right?
Yeah.
Okay. All right. So you know also that as we get older, our thirst mechanism doesn't always kick in, so you're aware that you need to continue to drink and eat well. Right. Okay. We have a thing that's called sensory perception, which is how well you move, touch, and your sense of things. So if there is a sense of pain that you didn't have, you could be incurring injury to yourself. So tactily, you feel that you can sense things that are going on. You're able to feel the pain.
Oh,
If we're
yes.
touching you now, everything is good
Yes.
with that. Okay. So we're just going to put gloves on, and we're going to take a quick look at your skin and make sure you're doing well.
Okay.
Okay,
fine.
thank you.
Part of the Braden scale, the dimension regarding moisture on the skin, involves doing a skin assessment.
So I'm just going to kind of...
It is also recommended that a thorough skin assessment always be done in combination with using the Braden scale.
What do you think we would be doing here relative to, again, to skin?
Assessing the site.
Okay.
The skin around the site.
Okay, and how is that looking to you?
Looks good.
Okay.
Looks good. There's no infiltration and everything's intact.
Okay. So anywhere we have a puncture, we want to check that too, or where we had a puncture before. So we want to check radial pulses and see if they feel equal, because again, that's going to give us an idea of circulation, and we'll do that all the way down to her feet. So you want to go ahead and check? Very good, thank you.
Very good.
Good palpable pulse, not thready.
No.
Okay, so
strong.
very strong. Okay. And we have such beautiful nail polish on, so I'm not going to be able to really tell your capillary refill, but one of the things that you can tell when you're doing assessments like this, there's a lot you can do without making obvious. Her skin is nice and warm. You can tell it just by checking her pulse. So you've already done a couple of assessments just in one touch. Also, when looking at someone, you can do a great assessment just standing at the foot of the bed. She's got pink cheeks. The whites of her eyes are nice and white, and she's very bright looking. So there's a lot of health that's going on in this body while she's healing. So those are good things. But those are some quick assessments you can do. Someone that's sleeping, you can do a lot just by looking. Okay. So now we're going to just kind of take a peek at your feet down here and check your pulses. Trying to keep you try and keep you as warm as we can while we're doing this, okay? So
Friction.
we're going to start talking about friction and shear, which we didn't when we were doing the top part of the body, but it's everything we go in friction, and shear is sliding across sheets, any kind of material that is rough against the skin, especially if skin is moist. Now, another thing that we were doing when we were assessing her, every time we touch somebody, we're getting an idea of what their skin is like, pulse, color. Is your skin moist to you?
No.
Yeah. Okay, so it's a good, healthy sign. If it was moist and we had a stocking like this here with this cutting against her, what would that?
It would start causing breakdown.
Exactly. Okay, so again, we're taking a look at the skin here. You're seeing a little bit of wrinkles. I'm going to lift this up. Now, what you're looking for in the heel is touch as well as vision, okay? If it starts to feel, if it's feeling a little mushy, or if when you're pressing on it, she's wincing in pain, or it pulls away or withdraws, that's an indication that there's some pressure there. If it looks like a blister, you know how you can get that sometimes from a shoe that rubs, you know how fast you can end up with a blister from that. Those are the things we want to look for, any kind of discoloration, redness. In some cases, it hasn't been assessed for a while. If they've been at home bedridden, you're going to find perhaps some necrotic tissue. It might look a little black or red, but you're looking for those types of things.
Okay.
Any place that you've got pressure. So we're going to have you turn it. We're going to help you turn because we're going to take a look at your shoulders, your spine, and your sacrum. Okay?
Which way am I going to turn?
Which is the most comfortable for you?
Well, either way is okay. I'm a big help.
Can you turn
Yes.
that way? Okay. Let's cover you up here for a second. Is it easier if I put the bed flat first for you?
No, that's fine.
Okay. Now, can you lay comfortably? And are you warm enough like this?
Yes.
Okay.
I'm fine now.
Okay. Now you can see just a little bit of lane. She's only been in this bed for a little bit. How quickly you get. So it's important when we have people, especially that are immobile, but anyone that's in bed, always pull those sheets tight because again, if it starts to crinkle up and they're moving back and forth, you're getting that friction. If you're moving someone across sheets like that, you get that shearing. Okay, bony prominences. Looks beautiful.
Yeah,
There's
nothing at
nothing
all.
there. But you can imagine if she wasn't robust and healthy like this, how that would be good, big pressure points. And then you'd want to be in constant awareness of that and moving people. Her spine looks very good all the way down. And again, as you're touching, you're feeling temperature, moisture, dryness. Okay. And here we're looking at the sacrum. This is the biggest problem right here for people, and hers looks very, very good. But this area here, again, because of the pressure, you've got your hip bones here laying on something hard, no matter how soft the mattress is, that's going to put pressure there. And this is where you're very likely to see skin breakdown if you have had anyone in bed for any length of time. So always look for that. And then there's things that you can do if you start to find that. We check with the wound nurse. We've got some protocols here for things we can put on the skin to protect it. And obviously, maybe Q1 turns as opposed to Q2, and moving the pillows and things like that. Okay, so knowing how healthy and adequately her nutrition is at home, what things would you want to look at for a patient, either in the chart that they're having now or what they go home, that could cause skin problems?
Medications that they take if they're on steroids.
Okay, and what happens with steroid medication?
It thins the skin.
Makes it kind of paper-like. Again, perfect for that friction. And then you'll end up with these little micro tears that can become easily infected, and then you end up with your skin ulcers. Okay, very good. So I'm going to have you turn back onto your back. Remember to breathe out. Okay. Okay. Now, you came through your surgery really well, but I imagine you probably had oxygen for a little bit while you were there. Another place that people sometimes forget to check when you have oxygen with that nasal cannula, with that the tubing that comes down over the ear. She wasn't on it very long. Some people are on it for days and weeks and months. Look here behind the ear and along the top of the ear, because this is where that tubing rests. And you will often see skin break down right across the top of the ear here on either side. Take a look at the back of the head. In fact, you should look at the back of the head of anyone that has been laying in bed for any length of time, because there's another area of pressure. And if you're turning someone and their head is staying straight on the pillow, you're not relieving that pressure. I saw when we turned you, you actually turned yourself. So I see that you're able to do that relatively comfortably. And when you're with PT, they're helping get out of bed. Are you using a walker?
Yes,
Okay. Are you just standing at the side of the bed, or have you been walking?
both.
How many times a day have you been up and walking since you've been here?
I think twice.
And your surgery was when?
Monday.
Awesome. Okay, so twice a day at least you're up and walking.
Yes.
Okay. One of the important things on the Braden scale is the mobility. And we're talking right now about the mobility of her while she's here, while she's in bed. And she's already told us that she's able to turn herself slightly on her own, but while she's been here, there have been people that have been helping her every 2 hours. So something we're going to have to take into consideration when we do our care plan for her going home is how is she going to be able to move and turn herself, and to make sure that that is something that gets addressed and that she can do easily.
Okay.
We need to have people up, moving, utilizing all of their muscles, getting that circulation, and supplying the skin with the nutrients that it needs to keep healthy. And again, with mobility, just because someone is walking, that's why physical therapy is important. Why it's important you asked about how her knee moves, because if someone is just moving stiffly like this, they're not getting the mobility of the joint. So we want to make sure that in what they're doing, they're able to move and bend. Do you have any questions for us?
No? You want to know how old I am?
Yeah, you know, I really do.
I'm 80, and I will be 81 in November.
Oh my goodness. Wow.
Oh my
81
goodness.
and
Well,
almost like
you're an
you.
inspiration.
I don't know about that.
There are a number of factors that cause pressure ulcers. The greatest risk factors have to do with two dimensions. One is pressure, and the other has to do with tissue tolerance. Unrelieved pressure over a period of time causes tissue ischemia, and that leads to pressure ulcers. Friction and shear, which is another form of pressure being exerted, are also related to pressure ulcers and cause tissue disruption. In addition, when people can't feel an area, they may have pressure and not be aware of it. And so sensory perception becomes an important piece. Similarly, having sensory perception but not being able to report it, either because of cognitive dysfunction or because of some inability to speak, also becomes a risk factor. The tissue tolerance piece has to do with external factors. Moisture is one of those. We know that moist tissue is more susceptible to disruption. We know that having poor nutrition makes you more susceptible to tissue disruption because that tissue doesn't have as great a strength. We know that being inactive is one form of exerting pressure. We know that being immobile is another. The incidence of pressure ulcers in hospitals is about 7%. This data comes from large data sets. The incidence in long-term care runs up to about 23%, and in home care it runs up to about 29%. The literature is quite clear that pressure ulcers are painful. Patients' own description is that they have endless pain with their pressure ulcer. Others describe it as though they had a toothache all the time in that area. And even with pain medication, the pain doesn't entirely go away. So they're very, very painful and need to be attended to reduce the pain. The pain occurs not just at dressing change time, but it's a constant pain that's there. One of the real risks of having a pressure ulcer is you have an open area. That open area may become contaminated with bacteria, and you may end up with an infection. With a very severe ulcer, a stage 4 ulcer, you may end up with osteomyelitis and the need for long-term antibiotic therapy. Or on the extreme, you may end up with sepsis and die. The factors that are seen as risk factors for pressure ulcers have been developed into the Braden scale. It was developed by Barbara Braden and Nancy Bergstrom, and it has 6 dimensions to it: sensory perception, moisture, activity, mobility, nutrition, and friction and shear. The first 5 are graded on a scale of 1 to 4, and friction and shear on a scale of 1 to 3. The individual is evaluated based on a history and a physical, and the data are input into the Braden scale. For a nurse that knows their patient, it doesn't even take a minute to complete the Braden scale. So with 1 being poor performance and 4 being the best performance, 1 to 3 on the friction and shear scale, you get a score, a total score then, of 6 to 23. And so the higher the score, the less your risk. The lower the score, the greater your risk. At a score of 18 or less, people are considered at risk. The scale subscales then are used to plan nursing care. So if your scale score is low in nutrition, then attention is paid to nutrition. If your scale score is low in the area of activity, then attention is given to activity, and so on with the various dimensions. The Braden scale normally is done on admission to all healthcare systems, and then the frequency with which it's completed varies according to facility policies. The sort of rule of thumb is that a Braden is done whenever the patient's condition changes. And in acute care, it's usually done daily. Sometimes in critical care, it's done every shift because patients' condition change that often. In long-term care, it's usually done weekly for the first 4 weeks of after admission, and then it's done quarterly, and again with any change. And with home care, it's done at every visit. Often when nurses see a pressure ulcer begin to develop, then they think it isn't necessary any longer to do risk assessment. In fact, the opposite is just true. So it's very, very important that patients always be risk assessed every day they're in the hospital. The Institute for Healthcare Improvement recommends to us that we do both a risk assessment scale and a skin assessment, and we combine them together and we do them routinely every day on patients. This is a change in our kind of thinking. We've talked about doing risk assessment on a daily basis, and most nurses have done skin assessment routinely. We just haven't put them together as a package in the past. Their recommendation is that we consider doing them, and we consider them as a package, because then you have both the patient's risk, and you can in fact identify by looking at the most common pressure points whether or not pressure ulcers are present. There are a number of challenges in using the Braden scale. The area of moisture is a difficult area. It's an area in which we have increasing problems in using the scale since we wear gloves to provide care. And often with gloves on, it's difficult to know how moist the tissue is. And in fact, sometimes what you have to do is look at your gloves to see whether they become shiny or not with that moisture present. And it is possible then to make a pretty good evaluation. In addition, the nutrition subscale is a little challenging to use. The challenge, I think, comes when you have a person who's well nourished, when they're living in the community, and then when they're admitted to the hospital, a number of things happen to them. So they may, in fact, not have good intake for a period of time. It may be several days. Well, at what point do you make a decision to move them from their usual nutritional status, would be evaluated as a 4, excellent, to less, and to less, and to less. And so that becomes sort of a clinical judgment that's made. I personally use the rule, do no harm. And so it, to me, is better to mobilize the dietitian the nutritional team early on in a patient's stay so that they can have maximal nutrition, and we can think about what we would do if that condition continues. In people with darkly pigmented skin, the ulcer manifests itself as a discoloration. So it could be a purple, it could be a blue, and often there's temperature differences that are used in that situation and a feeling of differences in tissue texture. There are 2 studies that show that the Braden scale works as well in Black Americans as it does in white Americans. Using the Braden scale to identify risk will not in and of itself reduce pressure ulcer incidence. What you need to do in order to produce reduced incidence is to act on the factors that you have identified using the scale as being risk factors. And so a plan of care needs to be developed around the factors that are identified as high risk for this given patient. There are a number of resources that people can use to think about how to prevent pressure ulcers. The classic is the AHCPR guideline, now available through AHRQ, and it's available online and it's free to everyone. Similarly, the wound, ostomy, and continence nurses have a nice guideline that can be used for prevention. In addition to that, the Institute for Healthcare Improvement, the IHI, has a guideline that they also have made available to us. And then there are wonderful, wonderful review articles in the literature that you might want to access in order to look at prevention. Many of these resources are cited in the companion article that's available through the American Journal of Nursing.
Additional resources regarding the Braden scale and its use can be found at the Hartford Institute for Geriatric Nursing website. There is also a video on the use of the Braden scale and a competency test. Information on these can be found at bradenscale.com.
So what we thought we'd do now is go through the Braden scale and take a quick look at what we may need to do to identify areas that she's going to need when she gets home. Karen and Nancy are here to join us. Karen is a dietitian. Nancy is a wound care nurse. And then Sherry is a student, student's instructor at De Anza College. And we have Andrienne and Patty. So let's just take a quick look. You have your Braden scale cards that we were using when we were in the room. We can go over it now, do the scoring, and maybe talk about things if we have issues, especially with the experts on hand, okay? First thing we might want to talk about here is, the first one is a sensory perception. And that's as we have it here, the ability to respond meaningfully to pressure-related discomfort, whether she can understand things, if she's able to follow commands. You've got the different ideas here. So how would you, based on the assessment you did for her, rate her on her sensory perception? A scale of 1 to 4.
I would give her a 4 because we checked her sensation. She felt, and she felt equally on both sides of her legs and arms, and she was responsive to commands.
Would you agree with that?
I would.
Okay, a 4, meaning
A
no
4.
no impairment.
No impairment.
Okay. Moisture, and that's the degree that the skin is exposed to moisture. Do you guys know what the 3 types of things we would be looking for in moisture would be?
Incontinence being one. Pain. When you're in pain, you sweat, diaphoresis.
Okay,
Wound drainage?
excellent. Okay, those would be the 3 main points. So
something else, I'm sorry,
Oh, yeah.
excuse me, that you might want to pay attention to is if the patient has a fever. Oftentimes patients will become diaphoretic if they have a fever as well. So, but she didn't have a fever, did she?
No.
No.
Okay.
So given that, again, on the scale of 1 to 4, 4 being rarely moist, 1 being constantly moist, where would we?
4.
Score.
I would give her a 4.
4.
Okay, I agree with you on that one also. Okay. Activity level here. Now, this is the degree of physical activity that she's doing. Is she bed fast, chair fast, walking occasionally, or walking frequently? How would you rate her?
I think walking occasionally here in the hospital, because she mentioned that she's walking 2 times a day up and down the hallways.
Okay, good. So we'll keep her as a 3 for activity. And now mobility. How would you rate her mobility 1 through 4? 1 being completely immobile and 4 being no limitation.
I'd say 3, slightly limited, because she was able to change position in the bed for us when we asked her to roll to the side.
Okay, so you were watching her make some slight changes herself in her body movement and that.
Yeah.
Okay, I would agree with that too. I'd say she's slightly limited. The big issue here is nutrition. Being a retired dietitian, she knows what she does need to eat, and she's probably pretty adequately eating well at home prior to the surgery. What do you think's going on now with her, and how would you rate her on this?
She's feeling a lot better, and she's eating and not having the nausea anymore. And since she was eating really well before she came into the hospital and eating a wide variety of foods, I wouldn't consider her a really high nutrition risk. So I would say she was between adequate and excellent on that. Probably adequate for now. Once she goes home and gets back to her usual eating pattern, then she'll be excellent.
Karen, I was wondering if you could tell me a little bit about how much protein this patient will need to have each day to help maintain her skin.
For this patient, when she goes home, as long as she's eating about 4 or more servings of protein a day, she should do just fine, because she has been eating pretty well and she doesn't have any pressure ulcers developed yet. And it also looks like her kidney function is normal. If she had less kidney function, I would be a little bit more concerned and she might not be able to tolerate as much protein. But since her kidneys are doing fine, 4 or more servings a day would be great. If she did have a pressure ulcer, then I would be more careful, and she would probably need more than that, and I would use an equation to calculate exactly how much protein she needed at home, and I would go over that with her specifically so she would know exactly how much to eat every day.
If the acetaminophen is not enough to control her pain and she needs to stay on the Vicodin, what could you suggest to her regarding the times that she's taking the Vicodin?
She needs to eat then as she's taking the Vicodin, so that it's a little easier on her stomach, because if not, she'll become nauseated, which she just then will not become mobile. So it'll hurt her both nutritionally and it'll hurt her in the area of mobility.
Right.
Yeah.
Good.
The last thing that we need to score here is friction and shear. And you remember what friction and shear is, okay? How would you rate her on that, where we've got 3 possibilities: your problem, potential problem, or no apparent problem?
Well, she doesn't require a lot of assistance to move, but there is that that part of sliding that she has to do because of her hip surgery and the past knee surgery in the past. So there is the potential problem, I would say. So I guess for me, I'd say 2.
Okay. Yeah, did you notice when she was getting out of the bed how she had to kind of wiggle or scoot herself? So there's that constant movement that way also. She's not able just to push herself up and move. So there is that aspect of it also. That is that friction and shear. So do you agree with all that with the 2? Okay. So we would give her a 4 for sensory perception, moisture would be 4, activity 3, mobility 3, nutrition we were giving a 3 for adequate, and friction and shear a 2. So we've got a total score here of 17, which would put her at a mild risk for any kind of skin breakdown. Did I add that up right?
I think it's 19.
Yeah.
Is it
Oh,
19?
19.
see, I needed something to thank you. So 19 puts her at even less of a risk.
Even though the patient in this case example was not at high risk for pressure sores at the time of discharge, the aspects of pressure sore prevention planning are the same, regardless of the degree of risk. The interventions are simply modified to meet the specific needs of the patient.
I think we need to talk a little bit about some of the things we would want to explain to her and help address, so when she goes home she does find that she is taking care of herself well and her skin is going to be adequate, that she's going to be able to exercise and do the things she needs to do to prepare herself for her next surgery. So I think that's when we need some assistance from everyone here at the table to try and come up with some ideas for her.
I just wanted to say something about shear that I think we need to bring up when we talk to them before discharge with she and her husband, that she not be getting in positions or become accustomed to positions where her head is elevated maybe like a 30 degree or so, which might be comfortable in her chair or in bed, where she has a tendency to have a shearing force, particularly on the sacrum area, because that would promote breakdown. In a shearing force, the weight of her own body is pressing against the skin, which has essentially stuck to the material underneath her. And as the weight of her own body will slide down, there's a shearing force, and it's an internal type of a tear that breaks down. And you see that sometimes in a coccyx wound, where there might be just a regular wound, and then all of a sudden you have a lot of undermining that'll develop because somebody's getting that shearing force and it's just breaking down and breaking down.
Nancy, I'm wondering, as far as discharge planning for the patient, she's elderly, she's going to be at home, things get a little bit more lax at home. As far as being here in the hospital, she's moved every 2 hours. Okay, she's repositioned every 2 hours. At home, she's going to be on her own with her husband, who's in his 80s. I'm wondering if it might be a good idea to suggest something like a memory foam covering for the bed, or something that's soft, that's going to relieve some of the pressure on the bony prominences.
Well, that's a really good question. One of the things about these mattresses that you see advertised is they're not really pressure relieving mattresses, and they're not pressure redistribution mattresses like we have in the hospital. We really need to spend some time talking to them about that process, and I'll go in with you afterwards and talk with them, because the husband needs to know, and she needs to know, that she really does have to change position on a regular basis. Every 2 hours is not really, the optimum. It's really better to change more often than that. And she needs to change position when she's sitting. She needs to change position when she's lying in bed, and relieve the pressure on the bony prominences, and that it doesn't become a problem, because she's not at risk now, but she could be at risk in 5 days. And it doesn't take very long to develop a pressure ulcer. A matter of hours can do it.
We've recognized that pressure ulcers are mostly preventable. It's a preventable problem, and so it's become cast as a safety issue. CMS has come to identify pressure ulcers as one of the never events, one of the events that should never happen to a patient. Pressure ulcer prevention is a critical part of the role of the nurse. Preventing pressure ulcers provides for quality care. It provides for safe care. I encourage every nurse that watches this video to embrace pressure ulcer prevention as a critical part of their role.